Hi, everyone. I'm Dr. Ashwin Vasan. I'm the president and CEO of Fountain House, and I'm just so pleased to host this virtual panel tonight and to share the virtual stage, the Zoom stage, with such a great moderator and a great panel. First, I'd like to just welcome everyone tonight and to thank our partners who made this all possible. Dr. Ken Rosenberg for making this wonderful and absolutely critical film and for joining us tonight on the panel. ITVS and WNET, who brought the film to PBS viewers and who partnered with us on the event. The Marshall Project, who has done really riveting, searing journalism around the overrepresentation of people with mental illness in the justice system, and has been kind enough to share with us their wonderful editor-in-chief, Susan Chira, tonight as our moderator. And of course, the National Alliance on Mental Illness, NAMI, and its CEO, Dan Gillison, who's also with us tonight, who represents the nation's largest mental health advocacy organization. For those of you who aren't so familiar with Fountain House, for more than 70 years, we have supported people living with mental illness to overcome social isolation and to build back the community and the resilience needed to live and to thrive in society. Fountain House is the most widely replicated community-based model for people living with mental illness, with more than 300 affiliated programs in the United States and in more than 30 countries. Fountain House was started with the belief that people living with mental illness needed a safe place in the community where they could go to really rebuild their lives, and that giving people back choice and dignity and possibility, while also providing the basic building blocks of a better life, healthcare, housing, jobs, education, all things that mental illness itself, as well as our punitive and inhumane systems, take away from people. That offers up an alternative to the status quo that the film so rightly shines light and critique on. Let me say briefly why we wanted to put together this event. You know, I'm a primary care doctor. I'm also a public health practitioner. And to us, we really think of mental illness as a public health issue that requires public health and community-based solutions, based in fairness, based in racial equity, based in equal access, and based in and rooted in a basic framework of social determinants of health. Because we know that mental illness, mental health doesn't exist in a vacuum. It doesn't exist independent from physical health, and it certainly doesn't exist in independence of community structures, community risk factors, trauma, and the collective risks and opportunities that our society disproportionately offers to some groups over others. But what we have in a current system is not that at all, right? We have a system that sends people to the justice system, that leaves people to live, often die on the streets, that relies on a revolving emergency room and acute care system door, all of which is suboptimal, poor quality, not very engaging, and costs all of us, in every measure of the word costs all of us in society more for getting very little. And all of which Ken's film demonstrates, in which my Fountain House colleague Issa Ibrahim can talk about from his own personal lived experience. We called this event Beyond Bedlam because that's our goal, really, to highlight the current state of affairs, of course, and to call out injustice when we see it, but also to try to think about and document and look beyond to new opportunities for a way forward. I'll have an opportunity to say more a little bit later, but with that, I'll introduce our moderator, Susan Chira, the editor-in-chief of the Marshall Project and former award-winning writer and editor for the New York Times. Susan, over to you.
Thank you so much, Ashwin, and thank you, Ken, for making this film. I hope that those of you who have tuned in tonight had the opportunity to stream it in advance. It's remarkable, it is wrenching, and it is very clear-eyed. At the Marshall Project, our mission is to examine the criminal justice system. We're named in honor of Thurgood Marshall, and in all our work, we are an investigative and explanatory journalism organization. and we look at particularly the inequities in the justice system. We look at racial, gender, income inequities and how they play through the justice system. And we have examined and want to continue to examine particularly the way in which jails and prisons have so tragically become warehouses for the mentally ill, among other inequities woven into the system. And that is an aspect that Ken's remarkable film, Bedlam, illustrates very, very clearly, that when a society doesn't have solutions or new research or appropriate funds, a lot of people end up being criminalized for behavior that in fact cries out for treatment, medication, and support services. So that's what our small team at the Marshall Project does, try to write about these issues using high journalistic standards. And I wanted to say, I think it's extraordinary that this film has come out at the very moment that the COVID pandemic has shed another harsh light on the breakdown of our public health system in the United States, because as Ashwin said, these are intertwined. And it is one of the areas that our team has at the Marshall Project has been working day and night on is COVID has now swept through prisons, jails, psychiatric institutions, and other areas where people are held close together. And COVID is also threatening the world economy and the United States domestic economy, so that it's going to take the monetary pressures that Ken so eloquently documents, the underfunding of mental health, and exacerbate that further on a federal, state, and local level. So I think this is actually a very important moment for us to consider the implications of this film. And I wanted to turn to Ken to talk a little bit about why you made Bedlam, you know, how long it took, what your journey was, and also what you hope people will take away. What do you hope that the film will lead to in terms of public dialogue and action?
Well, first of all, thanks for having me. It's an honor to be here. I mean, so many people to thank: Marshall Project, ITVS, WNET, Fountain House. I have long admired all of you. You know, I've made several films, and I made 4 for HBO, now 3 for PBS, but this was a special film for me because it was a film that I wanted to make about what I considered just about the greatest social crisis of our time. This was, of course, pre-COVID that we started the film. You ask how long it took. I mean, it took 5 or 7 years, but it's a journey of a lifetime. As you may know from watching the film or reading my book, I decided to be a psychiatrist at age 14. When I was in medical school, I studied film as well as medicine. But telling the story is a story that I really had not told, the story of my sister, the story of my family, and the story of kind of, you know, the millions of people who we have abandoned and neglected, marginalized. And really, even my profession, I'm sorry to say, as psychiatrists, we've neglected our neediest patients. And I think it was time for me to tell that story. That's why I did it. What's the point of it? Why do it? That's why we're here, you know, to tell the story and have a conversation. This is not the last film on mental illness, but is actually among the first films on mental illness, at least the first to be shown at Sundance Film Festival. When we showed the film at Sundance, to give you some perspective, I was shocked that we got into Sundance, completely amazed that we were one of 14,000 entries against Sundance. But I was more amazed that we were the first film that they had on serious mental illness. Mm-hmm. And I think that just, and they're, you know, wonderful, liberal people. They have the best of intentions. But again, I think as a society and as a profession and as individuals, we've neglected some of our greatest problems here. And in a sense, we've neglected our family and ourselves. That's why I made the film.
I think one of the very important points you make, Ken, is that in the film, you talk about the particular neglect of the seriously mentally ill. And as you say, many of this cohort, a cohort that Fountain House serves, and I'll introduce our other panelists in a moment, that all of you in some ways intersect with and have thought about, this group of people is fighting a lifelong disease. And it is sometimes, Ken's film shows the kind of roller coaster in which people show up at an emergency room, they are treated, get medication, often services. If they're homeless, someone's trying to find a place for them to stay, a community to help support them of care. Then in many cases, because that support is inconsistent or underfunded, it drops away. They go off medications, a psychotic episode occurs. And so it's a hard story. It doesn't have easy resolution. It seems cyclical and sometimes hopeless. And yet it is, you mention that it is in fact a story that was aggravated when, for good intentions, the federal government wanted to get mentally ill people out of warehouses where they were kept in inhumane conditions and try to move them into the community, the kind of model that Fountain House is talking about, but that the money to really support that kind of services has evaporated and was never there sufficiently to begin with. And so I wondered, all of our panels will be able to tell us something about it. Ashwin, whom everyone has met. I want Issa Ibrahim to just raise his hand to say hi. Issa is an artist. He is living with mental illness, and he has been incarcerated, both at Rikers, where there are estimates that 50% of those incarcerated there struggle with some form of mental illness or mental disability, but also at Creedmoor psychiatric institution, where about which he wrote his memoir, The Hospital Always Wins. We have Dan Gillison, who's the president, CEO of NAMI, which is the foremost advocacy organization for the mentally ill and their families. And then we have Ashwin, who can tell us now more about the Fountain House approach and how we might move beyond Bedlam.
Thanks so much, Susan. You know, I think as I mentioned in the lead-in, the film so elegantly and movingly critiques and shines light on a problem that most of us in society just want to push into the shadows. And, you know, I don't want to see it. Let's institutionalize it. Let's get it off the streets. I don't want to interact with it. It makes me uncomfortable. It reflects, it puts me at disease. So get it out of my purview. And as the film also rightfully calls out, is in the wake of the institutionalization, you know, our homeless shelters, our prisons, our streets, and our emergency rooms have become providers of first resort. And, you know, up to 45% of people who are chronically homeless in the United States have mental illness. Some estimates around 20% to a third of people who are incarcerated in jails and prisons around the country are mentally ill. When it comes to our healthcare system, this is a population that is amongst the highest drivers of cost, utilization, and poor quality care, because we just, as you saw in the movie, we don't have the systems in our healthcare system to set up to provide the kind of durable community-based care that we should be providing. And so, you know, the film does an incredible job of educating people about the problem, a problem that most people frankly don't want to talk about and don't want to see. And if we're not able to talk about it at the person level and at the family level, then how do we expect our politicians and our public sector, the people making resource allocation decisions, the people drawing up regulations and policy, how do we expect them to really take this on in a meaningful way? And so, this population becomes the political football of, particularly at the municipal and state level, it becomes the political football of local politics. It comes up when we're talking about homelessness, or it comes up when we're talking about, as you're seeing now with COVID, cleaning out the subways. It comes up when you're talking about crowding in the emergency rooms. It comes up when you talk about a horrible event in Rikers Island or in some other correctional facility, but it doesn't come up as a system or a strategy or an opportunity for us to marshal the resources, no pun intended, of course, to marshal the resources of the public sector to address it. And that's in part because as a society and as a political system, as a policy system, we don't see hope in the lives of people living with chronic, persistent, serious mental illness. We don't see that there's another future. I think the film nicely points out that this was always a population, has been and continues to be a population that is thought of as a problem, one to just push away. And so when have we ever invested in this population and thought, what does it mean to actually invest in someone's ceiling? To say that you have a qualitatively different life at your fingertips, that you can make choices. We can give you back that choice that's taken away from you by your disease and by society. So I think we need to be moving towards a conversation about what are the mass alternatives to these mass systems of punishment and poor quality healthcare and homelessness. And that requires that we start talking about not just what's bad about the system, but what do we build? Not just what we want to dismantle, but what we want to construct in its place. And it requires us having a intersectoral and really thoughtful conversation about what community investment looks like into things like affordable housing, into things like community-based healthcare, realizing the vision that John Kennedy had many years ago to actually invest and support community-based mental health centers. And it also requires supporting social infrastructure, places like Fountain House, that actually say, you can get care in the community, you can get housed, but you actually need something to do each day in a safe and dignified environment. You need to wake up, go somewhere, make choices, find things out for yourself, build skills, build relationships, much in the same way that everyone listening to this webinar does every day. And so we need to turn that conversation on its head. And, it's nowhere more important than now, when in the middle of COVID, where we're already seeing the disparate impacts of the virus on vulnerable populations. And that vulnerability thus far has been sliced by traditional demographic groups like race and socioeconomics, geography. But I would be highly surprised if we also didn't see people living with chronic serious mental illness fall on the butt end of this pandemic as well. And so now is the time. Not only do we have a coming tide of mental health issues, not only are we going to see rates of serious mental illness jump, as well as general mental health concerns, but we have a responsibility to ensure that this population doesn't bear the brunt of the pandemic, as we're already seeing vulnerable people do. So,
thank you, Ashwin. I wanted to ask Issa Ibrahim, because he, in our chats beforehand, mentioned some models that appeal to him, and also his concern about the inequities that this exposes. So Issa, please take it away. I just want to remind our audience in the webinar that if you have questions, please post them in the chat. And then at the end of our conversation, we'll try to address as many of them as we can. Go ahead, Issa.
Yeah, when I was doing a book tour for my book a couple of years ago, I went to Amsterdam and Montreal, and they both of the hosting organizations showed me their Clubhouse model, which was based on Fountain House, which goes back some 70 years, Fountain House. And they were sending drones, as it were, people and groups of people to Fountain House over the years to see what they were doing and implement it overseas and in Canada. And they're getting it right. maybe because it's a smaller population, or maybe because the culture is different. I don't know. But certainly in Montreal and also in Amsterdam, they've taken the Fountain House model and have a very empathetic and caring approach to the Clubhouse model that was started at Fountain House. And so it was good to see that we've seeded something that's taken hold elsewhere and done fabulously. But what I feel that it's good going forward. I believe everything that Ashwin is talking about, but we're ignoring the root causes of mental illness, I believe, which is trauma, poverty, and systemized depression. And you've got to really get it at the root before you can take it further and try to help it. I believe we're at a crucial juncture where we as a society and civilization can make the leap from fear and reluctance to talk about these core issues intrinsic to the foundation of America, and begin an honest dialogue with an emphasis on healing all Americans, the oppressed who need to be validated, as well as the oppressors and their children and grandchildren who are driven equally insane by the misdeeds and mismanagement of the country. I think there's a general malaise and illness that exists in the culture that needs to be addressed. And getting to that, taking that deep dive is asking a lot, but I think we have the ability to reset right now with the economic disease going on, with the quarantining, with just the country and the world being shut down and stopped. I believe now would be an excellent time to just reflect on ourselves, what got us here, seriously, and what can we do if we're going to start again to make it better. This is a perfect opportunity.
Yeah, Issa, I think it's an interesting point right now when everyone's lives have been completely upended, and we're all suspended in uncertainty and facing a kind of recreation of whatever normality is for the uncertain years ahead. Some people have said, so we have an opportunity to rethink the society we have. Whether or not that will happen, but I wanted to ask Ken also to engage in a dialogue with Issa a little, and then we'll move to Dan about, so as someone living with mental illness, when you look at the film, how well do you think it captures that experience? And when you think about how to reimagine the bleak reality that it portrays, what do you think can be done? Maybe Issa and then Ken, and then we'll go to Dan.
Ken earlier at the rehearsal, I thought it was very well researched, and it's an excellent primer to what mental health is in America. But I'm sure he went deeper in his book, but in the film, where I know you have to kind of cut corners and cut to the chase, a lot about systemic oppression and white supremacy and male supremacy and a lot of things were left out or just ignored. And those things really need to be talked about, because that is the root of a lot of people's mental problems.
Ken, you want to talk about that a little?
Yeah, no. As we said earlier, I mean, I couldn't agree with you more. I think that, in the film, it's more or less a cinema verite documentary that we didn't cherry pick 4 people and want to tell a certain story. We just found those folks and followed them for 4 or 5 years. I do think, though, that Patrice and Monty's story does tell the story of structural racism, oppression, and thank God Black Lives Matter was started because of that. Black Lives Matter was started while we were filming by one of the subjects in the film, which is mind-blowing in of itself, right? So I think, we went where the subjects went, but in the book, I do, to the extent, I'm not a sociologist, it's not my expertise, but to the extent that I could, I did talk about the role of poverty, substance abuse, structural racism, not only in making these problems worse, but starting these problems from the get-go. So I think your points are very well taken, and I think that's exactly the kind of conversation I want this film to spawn.
Great. I wanted to turn to Dan now. You're a relatively new leader of NAMI, and you came to that organization with a long history from NACO, and you were involved in the Stepping Up initiative. Can
Yes.
you tell us a little bit about how you've worked and what you think is effective to move people who are mentally ill out of prisons and jails where they cannot get the services that they truly need, into more of a community-based system? What have you seen work, and where do you think we need to go?
Well, thank you, Susan. And first of all, on behalf of NAMI and over 650 state chapters and affiliates, we want to thank you, Fountain House, WENT, ITVS, the Marshall Project, Issa, and Dr. Ken Rosenberg, because what we're doing tonight is critically important, and what Ken did in terms of bringing this documentary to all of our living rooms, as well as the book, is that he's made the invisible visible. And that includes the families. This book tells a very powerful, and the documentary tells and shows a very powerful story on what happens with the family, and gives some credence to that family need for support, which is the background and the backdrop for NAMI, which started 40 years ago as a grassroots organization by people sitting around a kitchen table looking for support for their family members suffering with schizophrenia. So you bring it full circle 40 years later, and answering your question, talking about stepping up and having visited about 15 different jails across the United States. We look for systems of wraparound services, and we look for communities that, first of all, they have to have the leadership. They have to have the wherewithal to try something different and to do something different. And then they have to have the economics to do that. There are a few communities that are trying it. There is no community that's got the full circle of services that are needed, but there are some that are absolutely trying to do it, and we're looking for a model that is sustainable and that can be replicated and scalable. So that's the opportunity and the need. And I would say that as I look at this, I also look at this, you mentioned, you asked about COVID, and I play this back to Katrina and the storm that hit Louisiana, and the Army Corps of Engineers was telling everyone that would listen long before the storm that the levees would not hold up. Play that back to what have we been saying long before COVID, that we had a fragmented mental health system. So here we are, and the question is, with that fragmented health system coming into COVID, what are the things that we can do during COVID to absolutely fill some of those gaps and then come out differently? I think part of it is the conversations, and secondly is some of the assets and the tools that we're doing right now from the standpoint of the telemedicine, telepsychiatry, and some of the low-hanging fruit like that. But this is a much bigger and deeper conversation.
Yeah. I want to turn to Ken for one sec and say, obviously there's no one-size-fits-all solution, but if you were trying to look at, if we have the luxury of reimagining this system, and I don't know whether we do, but if we do, what would be, from your years of practice and from this journey of making the film, where you'd like to see the first couple of key steps?
Well, I think the most important step is advocacy and activism, just what we're sort of talking about and trying to generate tonight. We see that it's sort of like when you say, if you could have 3 wishes, what would you wish for? 10 more wishes. But I think that here it's an important point, because we see in HIV. HIV was a death sentence in the 90s. It's a manageable disease, a very difficult disease, but a manageable disease now. Cancer, the same thing. Breast cancer in particular has made great strides, largely because of people doing what all of you are doing here, which is being activists or advocates. And that's what I think the one thing that will change the conversation. I think we might have new presidents, we might have new mayors, and people will come and go. And President Kennedy launched a very wonderful initiative with community mental health, which Fountain House is realizing. But Fountain House is only one place, and we need that across the country. But that cannot be sustained by a president or one institution. It has to be sustained by a country that says mental health is a priority for us. the World Health Organization has clearly, identified that mental health has a cost burden, the cost to us in society, that exceeds that of all non-communicable diseases combined. Now, of course, this was pre-COVID, that might change, but still, mental illness is our greatest disability. But still, when we look at funding for research, funding for resources, it really lags behind. So I think advocacy is the number one thing. The number two thing is more community mental health of the type that President Kennedy wanted to have, but was never realized. Community mental health that can accept people who are sick, not just people who are kind of the worried well, which is ultimately what happened. And funding that's sustained, not just for 2 years or 3 years, but for many years to come. It was good to get rid of the asylums, but it was bad to trans-institutionalize people, to take them from dreadful asylums into worse streets and jails. And I think that is the kind of trajectory that we have to change.
Yeah, I just want to turn to Issa for a minute as someone who journeyed through a whole bunch of different places, including the horror of incarceration as a way to deal with mental illness. I should just say one thing. As a journalist, I'm not formally an advocate. What we do try to do is unearth things that we think are abuses. We don't prescribe any particular programs, but we try to shine a light on things that are not right. But Issa, tell me from your perspective, what you think that the film has brought to light and your own experiences feel, particularly I think about breaking this link between incarceration and mental illness, because it, we have, as you pointed out, the homelessness, and then you have people, as we saw.
Yeah, I mean, you've got homelessness. I go around New York City when I was going out, before I got locked down like everybody else, and I see nothing but homeless Black men around my age, in their 50s, 40s, and 50s. I mean, and that's the whole generation of talent and integrity that's been flushed down the toilet, and it just continued, just languish. And so, as far as a prescription, I agree with Ken, but I think if we had proper leadership at a time when we were all locked down, I think that proper leadership would take us in a direction to say, hey, let's start something different. I mean, it's all the leadership, and we don't have it right now, unfortunately. And it's up to all of us to defer to our better angels. And some people are lost. So without that guidance, to think about a better way of treating each other and regarding each other, it may end up continuing after they reopen the country, and it may even be worse, considering that there are now something like 33 million people out of work.
Yeah.
So I couldn't imagine what we should do, considering what we could do, what we're not doing at this very moment.
Yeah. I want to turn over to Ashwin and Dan. I also want to remind our viewers, please put any questions into the chat, because we will be addressing your questions a little later on. But Ashwin and then Dan, do you want to address some of these issues about how could we reimagine? I know that Fountain House has a very compelling model with a lot of success, but it's not everywhere. And the money, I think, is going to be such a challenge in this next era.
I think that's actually a missing piece of the conversation, is that the solutions have been rooted so much in healthcare and in psychiatry, but actually at the end of the day, as I said in my previous comments, people need a place to go and do stuff, and to do so safely, and to do so as an alternative, and to have their basic needs met as well, the social determinants of health. But at the end of the day, social determinants of health without a life to live or to recapture doesn't mean much. So, I think it's a misconception to think that these are boutique projects. There are like 200 Clubhouse model projects in the United States. They just are deeply underfunded. Fountain House happens to be the leading light in that world and the one who started it all. But we don't talk about the rest of them because they're funded on budgets of like $500,000 a year or $750,000 a year. What can you do for that kind of money in at the scale of this problem, right? At the scale of this need. It's no surprise. And then you've got millions of dollars being sort of invested, for lack of a better phrase, into correctional systems, into healthcare, emergency care, acute care. And so we need to have an orientation back to that community mental health conversation, at least. It's not about one model. And certainly Fountain House doesn't exist in isolation from the rest of these systems. We're one of the largest supportive housing providers in New York City. We have our own federally qualified health center. We know that these things work together, right? We know that packages of investment need to be packages, and they need to account for that intersectional, the components of the building blocks of life. And so I guess all I would say is that I think we need more investment and more evaluation of these models, because the alternatives are out there. We've just never bothered to try. We have just never tried. There's never been a galvanizing movement to actually try to invest in mental health in communities. And, you know, I liked what Ken said about HIV, and that's how I started my career in HIV. And yes, it was built on the back of advocacy, but it was also built on the back of people with lived experience being those advocates. And so we need more people like Issa. We need more places like Fountain House and more collectives of people to stand up and show their voice, and actually show that they have a voice that is not what we think it is, but rather it is one of compassion and dignity. And so I think in order to actually change that conversation, we need people with lived experience speaking up for themselves as well.
I think that's really important. And one of the things everyone said is this is making the invisible visible. But here's the thing. Actually, so many people love someone who has mental illness. You know, Ken tells the very haunting tale of his sister, his beloved older sister, who, you know, unfortunately, treatment was not given to her. I have a cousin I adored who's lost completely to schizophrenia. I know many people who, and you know, in the film, you show how families either become advocates or engage in denial. So I wanted to talk, because NAMI has been a real advocacy group for families trying to make sure that they get the kind of care and resources allocated for this. So Dan, tell me what.
Yes, we have programming family to family, peer to peer. And one of the most important things is in our peer to peer is having someone who has lived the experience and can speak to what the individual and or the family is going through. So we provide education, support, and advocacy in that way in many communities across the U.S. And what's so compelling about that is that we understand the ebb and flow of that community in terms of how it works. Each community works a little different, so we need to be embedded in that community. I want to get to what Issa was saying about, you know, to a certain point, the social determinants of health. There's a book called The Social Determinants of Mental Health, and it really peels the onion back several layers and tries to examine the root cause and get us to look at the root cause versus the symptoms. What I would offer to you is that if we could look at three locations where there was a great palate, there was a great appetite in the leadership for change, because follow the money. Right now, all the money is in the county jails. I have been to Cook County 3 times. I've been to LA County, spent a day at the Twin Towers. Nothing like Ken in terms of the amount of time he spent there. I've been to Shelby County. I've been to about 15 different jails, and I've seen diversion centers. I've seen some really cool solutions, crisis systems at place, and with the Crisis Now movement. However, what I would say is that if you were looking to create a model that is scalable, that gets to that root cause, look at 3 communities that has the leadership and the tolerance for doing it and go after that. If you follow the money, the county jail system is where all the money is going. If you talk to the law enforcement, National Sheriff's Association, They don't want to be the caregiver and the ipso facto mental health hospital. That is what has occurred. They would like for it to be different. So there is an appetite for it to be different. It's just who's going to start making it different. So I would offer to you that that would be something significant here if we can find.
I think it is actually really interesting that, in fact, in criminal justice, there has been an interesting confluence of left and right. There has been pressure on the left for decarceration, and there's been pressure on the right for what they consider the wasteful cost of incarceration. And so there's actually been a very unusual bipartisan sense that mass incarceration is a bad idea. But I'm not sure it's entirely extended to the idea of mental health. So I think that we are going to move to audience questions now. And please continue to put some questions in the chat. I think to start off, we have a question from Ellen, who said, aimed at Issa and your perspective, but others can join in. What do you think of peer-to-peer lived experience as a way to help others? Can you address that for Ellen?
Yes, Ellen, thank you very much for that question. That's been one of the key things that have helped me maintain and tether to the community and remain healthy. I'm fortunate to be accepted by grassroots organizations like the Icarus Project and the Institute for Development of Human Arts, and of course Fountain House, and just having a community of people that I feel close to and can understand me in my weaker moments, as you could say, and I can see myself in them when they're struggling. To know that those organizations are out there has been a wonderful buoy to my spirit and allowed me to stay healthy.
Yeah, I would say that.
Go ahead, Dan. Yeah.
Lived experience. We try to walk the talk, if you will. 70% of our board is representative of individuals that either they or a family member has lived experience, as well as our helpline is actually managed by and run by individual volunteers, all with a lived experience. So when that call is made, that peer is calling someone who has walked in their shoes, and we try to make sure that that peer-to-peer is happening, because the person closest to it is going to be the most authentic and be able to actually interact successfully with the individual calling our helpline.
Right.
Thanks. We have another question from Carrie, initially directed to Ken. She thought the film was really well done, but as someone who lives with mental illness, Carrie says, I feel it should have included success stories. They're getting better. There are things that work. Have you thought of making a sequel?
Every day I think of making a sequel, and I surely will. Since medical school, I've been making films about mental illness and families struggling with illnesses of all kinds, mental and physical. So yes, and I'm sure there'll be more success stories, but I would add there are success stories as I see them in this film. Certainly the triumph of Patrice and Black Lives Matter in moving us from incarceration to treatment, community treatment in particular, is a success story. This success of Delilah, the young girl who we see when she's 11 years old, and then is now a freshman in college. She's a success story. So I think there are stories out there. Again, we didn't cherry pick them. We didn't look for people who were going to do well or poorly. We just followed people with serious illness. But I think that I don't see them, the difficult stories or the failures, if you will, in the film as being failures of individuals. I think they're failures of our system, of a broken system, which needs to be fixed.
I have to say, I was very heartened by Monty and Patrice. As someone who's got a mental illness and whose family abandoned them, my family abandoned me, and I had to make a new family, a chosen family, people who supported me and loved me, and to see the love that she had for her brother, and to see what it created was really outstanding. So I did enjoy that.
Yeah, I think that was very moving. Ashwin, I think you wanted to make.
Yeah, I wanted to say also, I thought the story of Delilah, I thought was particularly moving because it speaks to also the public health side of what the opportunity is. Early intervention, if there's one thing that we should be able to get behind, I mean, we should be able to get behind all of this as a society to support people living with mental illness. But if we can't support our youngest people, children, basically, who are coming up with mental health issues that are undifferentiated, you can't call them serious mental illness at that point, but who will evolve into serious mental illness if we don't intervene early enough. At Fountain House, we often get people in their 40s or 50s after living 20 years with untreated or undertreated mental illness. But we launched a college reentry program about 5 years ago, where now 90% of our students, after dropping out of school due to mental health issues, just like the first character, Johanna, in the movie, they end up back in school within a year. And it's because of exactly what Issa said, which is you got to give people a community where they can see themselves reflected in another person, where it's not institutionalized, it's not purely therapeutic in the classic sense, and it's actually just about existing in a place that feels safe and supportive. And so if we could coalesce around a couple of ideas, it's about models, of course, but it's also about intervening earlier. It's about connecting with people before they get to the point where they're classically seriously mentally ill. It's about getting people when they're starting to show problems in school and starting to show problems in the home, and coming from troubled communities and families. I think Issa's right. I mean, I think the connection between childhood trauma and serious mental illness is well documented. So we need to be thinking about this much further upstream in terms of secondary prevention.
Upstream
Dan,
is
did you want to
critically.
say?
Yeah, I did. Thank you very much. Upstream is critically important in early intervention, and we're talking about in the 14 to 15, because it takes 11 years for those situations to reveal themselves. So you're now talking about a 25-year-old. So if we can really focus on early intervention, and then as a part of what we're focused on in our strategic plan is early intervention, and then getting the best possible care, and then also the over-criminalization of the mentally ill in the justice system. Those are our 3 planks. But that early intervention is critical because it also goes back to getting potentially to the cause versus you get them on that treadmill, and the rest of their life, you're just dealing with something that if you had intervened early, you could have captured this and made it something that they could live very successfully with sooner.
There's another question I want to put to Ken first, and then others, because I think it speaks to something else that we talked about a little bit. A question from the audience didn't identify themselves, but when we release individuals with mental illness who are now inappropriately in prisons or jails, are there sufficient mental health professionals to provide treatment and medication? And one of the things that Ken has said to me is that, in fact, it hasn't been, there have been not a lot of this incentives in psychiatry to treat the seriously mentally ill. It doesn't pay. There isn't enough resources. There aren't necessarily enough people who devote their careers to it. So I wonder if you could talk a little about that. If we can let people out and say that the prison is not where they should be.
Right. Well, it's a very complicated question, but to answer it in a minute. In the film, we see an example of that. Monty went to a mental health court, and the judge said, you don't have to go to jail, we'll send you to treatment. Well, it took several months to find a treatment facility that would accept him. So we have to get the courts to divert people rightly out of jail and into treatment, but then we have to have the treatment to follow up. Now, having said that, we have the money, we have the people. What do you think is the fastest growing sector of psychiatry recently? Jail psychiatry, because that's where the patients are. If we would move the patients into the community mental health centers, community mental health center psychiatry will be the fastest growing sector. So I think that if we put people where they belong, where they could get fair and decent treatments, the treatment providers, the hospitals, everyone will follow. but it's a matter of incentivizing, or I would say properly paying for these services. And as I said earlier, making it a priority for our culture, for our society, to say that these folks, we ourselves matter, and we need this kind of care.
Ashwin.
Yeah, just quickly, I mean, this is exactly where this starts to intersect quite directly with our conversation around healthcare in this country. You know, we don't have mental health parity, as many of you might know about. Mental health providers are paid at 83 cents on the dollar compared to physical health. 111 million people in the United States live in a mental health professional shortage area. So we have a huge issue of access, and not enough insurance plans actually include basic mental health benefits, let alone benefits for the seriously mentally ill in their plans, which has over the decades, in addition to deinstitutionalization, driven psychiatry into private practice and away from community-based solutions, and has put an undue burden on social work and counseling psychology, which is few and far between. So, you know, we really have to bring this issue of mental health care into the mainstream conversation around healthcare reform in this country. And, you know, one of the potential silver linings of this terrible pandemic is that we're actually seeing telemental health services explode. The majority of new telehealth visits for most of the big payers are mental health visits. And so those need to be made permanent. We need to create parity in those visits. And we need to fundamentally change the way people get access to mental health care, which is in places like New York City, where I live, and Ken lives, is a privilege for most. It's not a part of basic frontline healthcare. So that has to be also mainstreamed.
Sorry, I'm unmuting. Two quick things because we're winding down, but this is a great segue to another question that we had, which was, you know, someone mentioned the power of activism and advocacy and AIDS as a model HIV. What then would you press for the most fervently? And Issa, someone in the audience wanted you to introduce your partner.
Yeah, Susan, come say hi. My partner, she's also a very talented artist herself, and writer and actress.
Yeah, I'm at the Fountain House Gallery.
Yeah. So.
I guess if I could say something quickly, I loved your film, and I'm so sorry for your loss, Ken.
Yeah.
My heart goes out to you, and I just wanted to say that, you know, I had to get treatment outside the system because the system really failed me, and that the medications didn't work, stuff like that. And why I was so resistant to treatment for such a long time is that, you know, I was abused on many levels in the system, and I didn't really care for the doctor in the film, Dr. McGee, who comes out looking like a hero, because I didn't like that she had a lot of power, but when it came down to the security guard, she let them restrain and physically hurt the patient. And me and a lot of other people who have mental illness were very disturbed by that, because we've been through traumatizing situations like that, where I don't feel that kind of force was necessary. And I don't like how she comes off being a hero when I just found her like very abusive. I also don't like, I think what needs to change is psychiatry's idea of how they talk to people, because when you see one young lady in the ER, she's talking and it's all of a sudden it's like she's psychotic. So they say, you have to take this medication, we'll give you a shot. But they never stop to listen to what she said. It sounds like gibberish. But I know from experience with myself and other people that a lot of that gibberish and psychotic talk, and she's trying to say something. And when she said blah, 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 the rape, she kept saying the word rape. And it was never addressed. And this is a form of trauma that many people go through. And if somebody would have taken the chance to really listen to what she's saying, so I think it was never addressed because no one really talks to us and listens to us. So I think talk therapy is underrated. And another thing I want to say is, like, I had to go to find a psychoanalyst who gave me a sliding scale fee outside the system because I couldn't find a connection with someone that was willing to listen to me and give me a real form of therapy, because in the system, there's no real therapy. So that's what I want to say.
Susan, I think it's great to have you make those points. I wanted to give Ken a minute to address them, and then we're going to thank everyone for your kind attention. Ken, go ahead and
well, I think that
respond.
I think it's a complicated, restraint is a very complicated issue, and I think it is hard to watch. And it is inappropriately done very often, and it's a big discussion. But let me just say, in the UK, you see, we're talking about other countries. In the UK, they rarely restrain people. In this country, we routinely restrain people. So that tells you there's some space for a different kind of conversation, different experience. I also think, Susan, you make a great point, which is empathy is the most important thing, and it's the missing ingredient. In all ways that I think that we really don't empathize with the struggles that other people experience, but I think that we try to ignore the struggles that we all experience. There's a few among us who don't have a mental problem of some sort, who don't have a psychiatric challenge of some sort, but and I think that what will change the conversation the most is if we start to acknowledge that and talk about our own struggles, our own families, because it's not like someone else's problem, it's our problem. I also just want to say before we stop that it's really important to thank ITVS, my co-producer who stood by me, MacArthur Foundation, who also stood by me, my co-producer and brilliant co-producer, I might add, Peter Miller, who stood by me, and my partner, Lenova, who stands by me with everything. So I just want to give them a shout out.
Well, that's wonderful. And actually, this comes as out my window, I can hear the 7 p.m. cheers and pot banging for our people on the front lines who are helping fight COVID every day at 7 p.m. in New York and maybe other places. We do that. And I feel that we can kind of extend that to our audience, to our panelists who have so bravely opened up their own lives. Ken, who exposed his own loss and who very much has helped us see what many people close their eyes and do not want to see. So thank you to everyone. I hope the film is widely seen, and I want to thank everyone for your thoughtful discussion today. Good night, and thanks everyone.
Thank you so much.
Thank you.
Good night.